Hello.
Shall we start? Welcome to Journal Journey of 1st June, jointly organized by Maharashtra IIP and Raigad IIP. This journey is a wonderful combination of young, dynamic speakers and their enthusiasm, complemented by insights from a vast experience of our mentor, Dr. Mohanty sir. To this academic feast, icing on the cake is by our dynamic experts. So, dear delegates and attendees, those who are joined, the today's topics are going to be appealed by people who want to stay updated. Happy learning. At outset, I welcome you all and request President Raigad IIP to share his thoughts. Over to Dr. Wankhede sir.
Thank you, madam. Thank you very much. And good evening to all. It's really very happy, very delighted to see this program, Journal Journey of Raigad, and upgraded by Maharashtra IIP to a towering height. We are looking forward a different speaker. They are giving their expert advice, and we get a chance or opportunity to listen them. It's really feast for us. Without wasting time, I extend my best wishes to this program. Thank you very much.
Dr. Wankhede sir, and now may I request our Maharashtra IIP President, Dr. Hemant Gangolia, to share his thoughts.
Thank you, madam. Good evening. Namaste to everyone. We are very fortunate to have Dr. Raju Shah as a chief guest for this today's session, as well as we have the experts, Dr. Abhay Shah and Dr. Omkar from Navi Mumbai as experts, as well as the young dynamic speakers for the presenting two articles. And of course, this is all going under the guidance of Dr. Nimen Mohanty sir. And I distinctly remember on last year, on the eve of the Doctor's Day, 1st July, we started this journal journey, and probably this myself and Dr. Jay Bhandarkar thought about it, and just we had a talk with Nimen Mohanty sir, and then we had this rollout of this. And I'm very grateful for that this has been associated with Maharashtra Academy of Pediatrics, and surely what we used to do in the PG days, reading the articles, but we don't, now we don't find time. So this is the opportunity to hear your young dynamic talents to talk about the articles and just upgrade our knowledge and update ourselves. So I wish all the best to the speakers, as well as wish each one and everyone who is attending this on MahaIP YouTube channel also a happy learning. Thank you, madam.
Thank you. Thank you, Dr. Gangolia, sir. And now may I hand over the screen to Dr. Ajay Pori, who is our Master of Ceremony today, to invite other dignitaries for their blessings. Over to Dr. Ajay.
Unmute.
Kindly
Please.
unmute Ajay sir.
Sorry, I didn't unmute. Hello, thank you, Chitra ma'am. I thank Dr. Chitra ma'am and our president for giving me this opportunity. I, on behalf of IIP Raigad, welcome all the dignitaries, the speakers and experts, and also our viewers for this academic feast. Continuing our journal journey, first I would like to request Dr. Narendra Nanivrekar, a senior pediatrician and executive body member of Maharashtra IIP, to give his blessings to this journey. Dr. Narendra, sir.
Unmute, please.
Yeah. Thank you, MahaIP, for having invited me as a guest for this program. And I wish both the speakers who are from my hometown, Dr. Vijay Mari and Dr. Prama Bhavna, a grand success. The reason why we go after Journal Club is because we want to keep ourselves updated. And it's not just that we keep the knowledge updated, because that anything which is new published is going to be used in our practice. And if that is used in our practice, then it is going to be of some help. So I'm sure both the topics which will be discussed today by both Dr. Vijay Mani as well as Dr. Prama will be helpful in changing the way we practice. Without taking much time, I wish them a grand success, and I hand over the proceedings to Dr. Kohli again. Thank you.
Thank you very much, sir. I would now like to invite and request our next guest of honor, Dr. Raju Shah, sir, National President, IIP 2005, to also say a few words and give his blessings to the journey. Dr. Raju, sir.
Yeah, thank you, Dr. Ajay. President of Maharashtra IIP, Hemant, Secretary Amol, Treasurer Dr. Jai, Dr. Chitra, and friends. It is indeed a great pleasure coming once again to this journal journey. Last year, as part of Raigad initiative, I was invited to bless this occasion, and now when IIP Maharashtra has taken over, once again I'm invited. I am really thankful to all the friends who have so close association with me and they respect me. This is actually one of the best activity of the IIP, because we all know that once we are in the practice, it is not that easy to get the journals or read the journals and give the timing. But when we share our views or read these journals in a group, it becomes easy and it becomes even entertaining also, along with getting the knowledge. So this is one of the best activity. I wish all the best, and I especially congratulate the speakers of today, both Dr. Prama and Dr. both of them, for taking this time, reading and serving the IIP to help all other friends to gain the knowledge. We have two experts today. My friend Dr. Abhay is there and Dr. Jamdar is there. Both are having a good knowledge and experience of giving their views as expert and guiding us in how these articles are going to help us in the practice. So I wish all the best to this activity, and thank you so much for inviting me to be part of this program. Thank you.
Thank you very much, Raju sir. Without wasting much time, I would now like to invite our first moderator, Dr. Jai Bhandarkar sir, to introduce the experts and the speaker and to start the first session. Over to you, Jai sir.
Yeah, good evening all. I think all senior pediatrician and dignitaries on the dais, and all the YouTube viewers and delegates. Friends, it started last year, there seems to be with every episode are growing in the number of the audience as well as the quality of the journal journey. So today we are again blessed with the first expert, that is Dr. Om Prakash Jamadar. He is MD Pediatric, MRCPH and DCH UK, and fellowship in neonatology in London. He is a consultant pediatrician and neonatology, Apollo Hospital, Navi Mumbai. Director of Nitai Children's Clinic, Nehru East, Navi Mumbai. And very happy to announce he was the first consultant I contacted during that academic quiz last year when we started in the Corona period, and responded very well. And he gives all neonatology questions was shared in the quiz was given by him. So welcome and thanks well in advance to Om Prakash for his kind gesture. Thank you. Over to Abhi.
Sir, now introduction of first speaker.
Okay.
Dr. Vijay Mali.
And we are again blessed with this young, dynamic, our first speaker is Dr. Vijay Mali. He is MD Fellowship in Neonatology from Manipal University, Fellow in Neonatal Intensive Care from Oxford University, UK, and is working as a concerned neonatologist at a nice advanced neonatal care center and children's clinic, and as well as he is associate professor at DY Medical College, Kolhapur. Welcome, Dr. Vijay.
Thank you. Thank you. Shall I share my screen?
Yes. Yes.
Yes, sir, go ahead.
Thank you, sir, for the introduction, and thanks for giving me this opportunity in this occasion. Is it visible?
Yes.
Yes, it's visible.
Yes.
Yes. Good evening, everyone. Today we'll be discussing about an article published in Archives of Disease of Child, Fetal and Neonatal edition in April 2022, that is last month. It's about short-term pulmonary and systemic effects of hydrocortisone initiated 7 to 14 days after birth in a ventilated preterm infant, a secondary analysis of randomized controlled trial. So what is we know something about why we use hydrocortisone, why we use dexamethasone. In background, it's a bronchopulmonary dysplasia, which is oxygen requirement at 28 days postnatal period or 36 weeks of postmenstrual age. And the incidence is nearly 40% among less than 28 weeks neonates. And mechanically ventilated preterms are likely to develop BPD quite often. And main pathogenesis being pulmonary inflammation, lung fibrosis, histopathologic evidence of arrested lung development. And the prevention, lots of trials has been done, lot of intervention has been done last many decades, mainly antenatal steroids, avoiding invasive ventilation, optimal nutrition, early surfactant. So on the physiological basis, the reason behind using steroids is that preterm neonates are in a state of relative adrenal insufficiency, which was proved in many studies, and so may not be able to control the inflammatory response. So postnatal corticosteroid dexamethasone have shown a positive effect on reducing incidence of bronchopulmonary dysplasia and a lot of RCTs, but can have hyperglycemia, hypertension in short term, as well as long-term neurodevelopmental adverse effects. So what we are looking for? We are looking for medicine that can decrease the lung inflammation and subsequent bronchopulmonary dysplasia, but without or minimal short-term and long-term side effects. So when we look at the two steroids, initially we used dexamethasone, now it's the hydrocortisone. So there is a lot of difference between the two molecules, mainly anti-inflammatory activity is 30 times more in dexamethasone compared to hydrocortisone. Duration of action is 36 to 72 hours in dexamethasone. For hydrocortisone, with just 8 to 12 hours. Mineralocorticoid action is nil. That's why these receptors are not activated with the dexamethasone treatment. So there is a evidence of neuronal apoptosis. That's why there is a long-term complications, the neurodevelopmental outcome, which is not seen with hydrocortisone. And effect is exogenous because this is a dexamethasone exogenous, by the hydrocortisone succinate, which we use, is like an endogenous steroid. So dexamethasone will suppress the production of the cortisol quite often compared to the hydrocortisone. So there's a major difference between the two molecules. So now the trials has been about studying the hydrocortisone in preterm neonates. So RCT data on short-term lung function changes and adverse systemic effects of hydrocortisone started of the first week are lacking. So the first trial has been registered in 2011. This is about STOP BPD study, and aim is to role of hydrocortisone in reducing the incidence of combined outcome of death and BPD at 36 weeks post-menstrual age in chronically ventilated preterm infants as compared to a placebo. So this STOP BPD study, once the enrollment was for less than 30 weeks neonates, so those who are less than 1250 grams. Outcome was, it showed that hydrocortisone does not reduce the risk of combined outcome death or BPD at 36 weeks post-menstrual age. And it is not associated with combined outcome of death or neurodevelopmental impairment at 2 years of corrected age. That was the primary study aim. After this study, they did a secondary in-depth analysis of STOP BPD of short-term pulmonary and systemic effects of hydrocortisone treatment compared with placebo. So main study design that's of STOP BPD was, it's a multi-center double-blinded placebo-controlled RCT, 16 neonatal intensive care units in Netherlands and Belgium between 15 November 2011 to 23rd December 2016. And the randomization is done by computer-based block randomization. Inclusion criteria for this was less than 30 weeks neonates with or those who are less than 1250 grams who were ventilator dependent between 7 to 14 days postnatal age and at high risk of developing BPD were eligible. Criteria for high risk for BPD was defined as having respiratory index, that is product of mean airway pressure on ventilator and the fraction of inspired oxygen equal to or greater than 2.5 for more than 12 hours per day for at least 48 hours. So initially when trial was registered, the respiratory index which was used was 3.5, but eventually when they realized even those with a 2.5 can develop BPD, high incidence of BPD, they enrolled these children as well. Exclusion criteria was chromosomal defects, major congenital malformation, or if received corticosteroids for improving lung function in the first week of life, because many units were using hydrocortisone as a rescue therapy as per the Primilov trial, and these children were not included in this study. Intervention done was hydrocortisone sodium succinate was given to infants allocated to intervention group in a tapered dosing scheme of 22 days with a cumulative dose of 72.5 milligram per kg. So 5 milligram per kg per day, 4 times a day for 7 days, and subsequently 3.75 milligram per kg per day, twice a day for 5 days, subsequently lowering the frequency by 1 dose every 5th day. This leads to a total duration of 22 days and cumulative dose of 72.5 milligram per kg of hydrocortisone. Here the molecule is hydrocortisone sodium succinate. So sodium is just for the stabilization, and many units have mentioned hydrocortisone hemisuccinate. Outcome of interest for secondary analysis were proportion of infants failing extubation, median time to successful extubation, effectively remaining on non-invasive support for more than 12 hours, 72 hours. Data on extubation were collected over 22 days period. Infants who died during the period were considered to have failed extubation. The parameter checks after the intervention were, these were checked daily, like mean airway pressure on ventilator, fraction of inspired oxygen, respiratory index values, and partial pressure of carbon dioxide, blood pressure, and blood sugar levels. This is the demographic data of hydrocortisone in the placebo group. Most of the parameters are matched with proper block randomization, and median gestation age was 25.4 weeks in hydrocortisone, 25.6 in placebo group. Weight is around 770 grams and 710 in both the groups. Male sex is almost 52 to 57%, and small for gestational age incidence is like 14% and 20% in hydrocortisone placebo group respectively, and only relatively high multiple births in hydrocortisone group, because here option was given to the parents about randomization. If there is a twins or triplets, parents will decide all will go into same block or they will go different. So that's why maybe their multiple birth are higher in hydrocortisone group, and antenatal steroid received almost equal in both sides, 87, another is 90%. The rest of the parameters in terms of ventilator setting at the enrollment of study and other parameters at the randomization, the mean blood pressure, systolic blood pressure, diastolic blood pressure, blood sugars level were checked and almost equal in both the groups. So what has been found? When they analyze the data and the parameters change after starting the hydrocortisone, they were recorded immediate next day, and the daily change of parameters, and after completion of the period, they analyze the data. What has been found is mean airway pressure, which is significantly decreased daily with p-value less than 0.01, fraction inspired oxygen is 0.02, respiratory index score was minus 0.37, and PCO2 was minus 0.04. There is a gradual weaning of ventilatory parameters as well as improvement in ABG parameters in the hydrocortisone group compared to the placebo group. Similarly, there is a level of slight increase in the glucose level, as well as mean blood pressures, systolic blood pressure, as well as diastolic blood pressures. However, the values are significant. Clinically, these children were never been symptomatic, and they are not in very high range, so never required any anti-hypoglycemic or anti-hypertensive medicine for the intervention group. So improved lung function was seen with hydrocortisone group extubation in the most infants at the median time of 9 days compared to 15 days in the placebo group. So proportion of the failing to extubation, the failed extubation was seen only in 24.3% compared to 38.6% in the placebo group. That is significantly high number of children failed extubation in the intervention group, as well as daily change of glucose level is just 2.52 milligram per deciliter, which was not quite significant. And initial 7 days, it has initial period when the hydrocortisone dose is higher, never required any anti-hypoglycemic medicine. Similarly, for the blood pressure, slight rise in the mean blood pressure of 0.83 millimeter mercury, but never required any medications or never been symptomatic. The limitations of this study is that high proportion of the placebo group was eventually treated with open label hydrocortisone. But for the secondary analysis of these parameters, it has not affected, but definitely it would have affected the long-term effect of assessment of neurodevelopmental outcome at 2 years of age, because nearly 56.8% was eventually treated with open label hydrocortisone. That means those children continue to remain on ventilator after 2 days of placebo therapy were given hydrocortisone, because some effect has been, because we want to decrease the inflammation, we want to get them out of ventilator. So open label hydrocortisone was allowed. And ultimately analysis was done initially for BPD and combined outcome of BPD and survival without BPD. At the same time, 2 years analysis was done after completion of the trial. So this open label hydrocortisone not affected the initial secondary analysis in this particular article, but may have effect on the long-term outcome analysis. In conclusion, systemic hydrocortisone initiated between 7 to 14 days after birth in mechanically ventilated preterm infants born before 30 weeks gestation significantly improves pulmonary condition, thereby facilitating weaning and extubation from invasive mechanical ventilation. Effects of hydrocortisone on blood glucose and blood pressure are mild and of limited clinical relevance. So when we talk about this article, it is not complete without discussing similar articles which will have a practical impact. One which was published recently is Primilab trial in the Lancet, which definitely says that here the hydrocortisone was used shortly after birth in 24 to 28 weeks gestation. And here outcome, what they found is higher rate of extubation of hydrocortisone group, significantly increased survival without BPD at 36 weeks, statistically significant improvement in neurodevelopment outcome at 2 years, and relatively lower dose and duration of hydrocortisone compared to stop BPD. So this is like prophylaxis hydrocortisone, where almost all the preterm neonates are exposed to hydrocortisone. So the outcome when they analyze it is very precise. So decision to use in a practically, it depends on the unit policy or it should be individualized. And dexamethasone RTs it shows that faster extubation, lower ventilator setting with 48 hours, but poor long-term neurodevelopmental outcome. So as I said before, Primilab trial has all the neonates are exposed to steroids, small sample size, and outcome is not precise, so not recommended uniformly. How this study might affect research, practice, or policy. Use of hydrocortisone is safer than dexamethasone in terms of short-term complications. We can use this information for weaning and extubation of the ventilated preterm neonates. It will bring down the cost of NICU care as well as the complications of invasive ventilation apart from BPD. So this was the article recently, 2 days back, it was published in Pediatrics. It's about review about all the postnatal corticosteroids to prevent or treat chronic lung disease following preterm birth in American Academy of Pediatrics. So routine use of RCT is cannot recommended, means we cannot use like 72 hours initiation, continued treatment is not recommended. So definitely we can use postnatal corticosteroids for prevention of BPD, as well as this will be helpful for weaning and extubation from ventilator. Thank you. So only I want to talk about the stop BPD study is that those which is used hydrocortisone is very high, which is equivalent to high dose of dexamethasone, but not caused any long-term adverse effect after the end of the study because it is more physiological and with lesser steroid, lesser anti-inflammatory properties compared to dexamethasone. And this was one more article which is published. It's about using a very low dose of hydrocortisone in the second week of life. Here again, outcome is the same, that weaning and extubation was quite early in hydrocortisone group compared to the placebo group, which was published in NEJM quite recently. And here also, long-term outcomes were not much affected, and it will not prevent survival without BPD. So outcome is same. So it will definitely help in terms of weaning and extubation from ventilator. Thank you very much.
Stop sharing, Dr. Vijay. Dr. Omkar, sir, your inputs.
Thank you so much, Dr. Vijay. It was an excellent overview of postnatal steroids. I think before we discuss this topic, I would ask everyone to remember the Cochrane logo. All of you must be familiar with the Cochrane logo, the circle with one vertical line and multiple horizontal lines into it. So this Cochrane logo is from the study of use of antenatal steroids, and it is 1960s when it was proven clinically that antenatal steroids are helpful. But we will say a classical example of how delayed presentation of evidence into practice happens is by use of this antenatal steroids. And same thing is going to happen with postnatal steroids. But I will say what information, what data we are getting is very limited. In neonates, the studies are very much limited, whether it is a steroids or any medications for that sake. But it was a good overview given by Dr. Vijay. So few points I will like to add on. First is dexamethasone or hydrocortisone. That is one. Then next is mode of giving the medication, whether it is an IV medication, oral medication, or inhaled medication. Now, dexamethasone is very well time tested. Many of us do use DART regime, which is like a very low dose of dexamethasone and which is tapered over a period of 10 days. And we do see immediate effect, but long-term data is very much lacking in Indian scenario. But what information in terms of the apoptosis effect that we are seeing with dexamethasone has suppressed the use of dexamethasone in coming times. And this is a recently published article that will help us to decide, instead of dexamethasone, we should move towards the hydrocortisone. And the Plimiloc trial, which was discussed again by Dr. Vijay, that they started steroids from first week itself. But I must say here that the risk of sepsis is increased in these babies when they were exposed to postnatal steroids from first week. So we need to be very careful when we think of giving prophylactic steroids for these babies. It may help us for giving a early extubation chances, but at the same time, it may increase the risk of sepsis. And again, in Indian scenario, the sepsis is a prominent killer for the extreme preterm babies for us. And BPD will come to the next stage, So I'll be very careful before we think of giving preventive CLD preventive steroids for babies who are less than 28 weeks. But we can think of using steroid from second weeks. So steroids are given early, mid or late steroids. So those which were used within 1 week are called as early. First week to second week, I'll say like a not late, but it's somewhere middle, and more than 2 weeks is late. So steroids which are given less than 1 week are noted to be helpful for prevention of BPD, but the complications risk are high. So second week steroids, I will say they are relatively safer. And by that time, we get an idea who are the babies who are stuck on the ventilator, who have a higher risk of development of CLD in their life. And third week steroids, they are not so greatly helpful, but at the same time, their side effect profile is lesser. The long-term complication in terms of the neurodevelopmental problems are lesser with the third week steroids, but benefit is also lesser at the same time. So that is about the dexamethasone and hydrocortisone given IV or orally. Next, which is coming in pipeline, is a inhaled steroids. And I will say there are very good promising results with inhaled steroids. There are many trials going on. And I know many of my friends, in fact, we also did use inhaled steroid for some babies in Apollo, and there are promising results. The trials which are available use higher doses, like almost like 600 to 800 microgram per day, but that is quite high dose. So what we have used in our practices are like 200 micrograms to 400 micrograms per day inhaled steroids that we have used, and that has been found to be helpful for these extreme preterm babies. We have used in twins. In fact, I will say it was like a in indirect randomization what we did, where we use for one baby inhaled steroids and when we use the typical dose of dexamethasone, and inhaled steroid was found to be quite helpful. So I will say next future in terms of the postnatal steroids is think of using inhaled steroids. The data is going to be come in a big base, and then that is going to be helpful in terms of prevention of the immediate side effect as well as the long-term side effects of neurodevelopmental disabilities in these babies. So that will be my take-home message, that we should look forward for this inhaled steroids. And for time being, given limitation of information in terms of the steroids as a dexa or hydrocortisone, many units they do still prefer DART regime. I'm sure many of you must be familiar with the DART regime.
And as well, the newer studies are coming about using surfactant with steroid. So if we get that more in detail, definitely that will be more beneficial as like rescue therapy rather than actual treatment for evolving CPD, like evolving.
Limitation of surfactant with steroids, I will say, because see, surfactant we give in initial time frame like 24-48 hours time, but CLDs develop over a period of time. So in that situation, the inflammation effect, the steroids duration of action, the T-half of steroid, if you see, it won't be prolonged like weeks and weeks. So that is the reason I will say it will be not a long-lasting effect with a surfactant and steroid. But yes, there are some studies, but I doubt whether that is going to be helpful in terms of prevention of the chronic lung disease in long term.
Yes, thank you, sir.
And even this study, I will say, it is the cumulative effect. This is actually not a primary result of this study. It is a secondary result of this study. So there they said like the outcome in terms of the extubation, chances of extubation, early extubation are better. It reduced the duration of ventilation by 6 days. And that itself must have helped us to decrease the chances of CLD. So whether it is not just the steroid, I will say. So steroid helping us to extubate babies earlier, and that decreases the chances of the lung injuries caused by the pressure changes that happen during ventilation. So that has also contributed.
Yes, sir.
One additional thing I must comment, that if you observe babies with chronic lung disease, if you observe their blood pressure, many times they do have a higher blood pressures, and that is because of the endogenous production of renin-angiotensin. So steroid, yes, they will aggravate the problem of hypertension in these babies, but the effect is not long lasting. The moment you stop steroids, I'm sure in 24 to 48 hours time, the blood pressure comes down drastically. It will come down in a normal ranges. So that's the reason we don't have to use the antihypertensives.
Thank you, Vijay and Dr. Om Prakash, for a beautiful discussion. I have a question. The previously when we had to ventilate, just we are giving steroid a single dose, maybe 12 to 24 prior, right, before extubation, and as well as in some account recommendation, I even nebulize the patient with this Budecort specifically. Whether the single dose of steroid itself has a, already mentioned hydrocortisone now better extrusion chances. Yes, and long-term effects are very less. I don't know whether because of this, I can say duration of the action of hydrocortisone may be very less. It's a very short-acting steroid, right? And dexamethasone is a long-acting. Whether that's long-acting effect of dexamethasone itself has a pure neurodevelopmental outcome later, whether that correlation is there due to that. The difference between this long-term neurodevelopmental outcome between hydrocortisone and dexamethasone.
That's very important question, I will say, sir. So what we use peri-extubation is a one single dose, or some units use 2 doses. But again, if you see, even in this study, they said nicely that it is the cumulative effect that they have observed. And chronic lung disease is not a one-day affair.
Right.
Babies who have not received antenatal steroids, they are at a higher risk. Babies who are on a long-term ventilation, they are at a higher risk. Those requiring higher oxygen, they are at a higher risk. So if you see the list, there are multiple factors. And out of these all factors, I will say the only one which is proven is maternal chorioamnionitis. That is one very significant factor associated with the development of this chronic lung disease. So short steroid, particularly single dose of steroid, as in this study also they observed, I don't think it is going to be helpful as far as the chronic lung disease is concerned, because it's a long-term process, lengthy process happening. So it will be helpful for prevention of the extubation failure, but for CLD, I don't think it will have got a great effect.
That when you ventilate the child or a neonate, specifically preterm, we are more worried of whether that you should reduce the days of ventilation, because it almost the CLD is correlated with the longer days of intubation or ventilation of the child, and more lung injuries are this patient going to have the more chances of CLD. When you ventilate patient, initially more of a worried about the मैं कितने जल्दी baby को extubate करता हूँ. I'm not worried of that was CLD. CLD the steroid usually come after like a चलो patient is not improving, then you add steroid, vitamin and other thing, diuretics is in later stage, right? So well said. Shorter duration of steroid or more of the exhibition purpose, and at that time we don't think of CLD much.
Yes.
Later on we think it, but now this study shows that 10 days or 12 days of steroid helps early extubation as well as prolong this effect or better effect or better prevention of the CLD in this patient. So any other inputs are there, you can definitely. Mohanty sir, you want to say?
Nowadays, sir, we do like non-invasive ventilation quite often, CPAP and everything. So in spite of that, we stuck up on ventilators, then these things will really helpful as a new intervention to get them out of ventilator earliest. Because apart from that, we are trying non-invasive, early surfactant, a lot of other things, and like volume guarantee ventilation, a lot of other intervention. But if really we stuck up on ventilator, then apart instead of dexamethasone, we have other best options, hydrocortisone.
Whether with hydrocortisone steroid, irrespective of patient had infection or not. So patient, if we use steroid in this patient also, in all patient?
Yes, sir. Those who are infected, also they have the relative adrenal crisis will be there. And these doses are minimal and their physiological effect is seen, not like, even in Primilog, there is a mild sepsis risk was seen, but it was not affected the mortality or hospital stay. So it has not affected anything, provided we have to take the standard precaution, because the unit-wise outcome may change because the policies are different in different units. So if we have an aggressive management, strict antiseptic precaution, definitely these interventions should be done to get them early out of ventilators.
Yeah. Okay, you can stop sharing screen now.
Yeah.
Inputs from Mohanty sir, if any. Sir, unmute kijiye sir.
Yeah. Sorry. Thank you, Dr. Jay. I must thank Dr. Vijay.
Dr. Vijay, sharing stop kara.
Very nicely, yes, he has presented, and all this aspect he has covered. We discussed it earlier also. And I think, see, the duration of the hydrocortisone only for 5 days, 5 to 7 days. Then they started tapering after 3 weeks. So short duration was not long. This is not a very long duration. When you are giving steroids, you must rule out infection. Maybe sepsis screen, other things, blood culture, everything has to be done. In your early day, we say give steroids under control, cover of antibiotics. So consider antibiotic, the baby may need any time. That's it. That precaution has to be taken. Yes. Thank you, Dr. Vijay, for a nice presentation.
Thank you, sir. Thank you very much. Thank you.
Sharing stop kara, Dr. Vijay.
Dr. Vijay, please stop sharing your screen.
Yes, sir. Yes, sir.
Hello. Thank you, Dr. Vijay and sir, for the nice and wonderful presentation. Now, without wasting much time, I would like to invite Dr. Vikas More, Secretary of Raigad IIP, to start the next session by introducing the next speaker and guest expert. Dr. Vikas.
Yeah. So on the behalf of IIP Raigad and MAHAIP, we are very, very fortunate to have Dr. Abhay Shah sir from Ahmedabad as an expert who worked as a national scientific convener in IIP Action Plan 2021. I also welcome Dr. Brahma Bafna, who is a speaker today and who is a prominent budding pediatrician and neonatologist from Kolhapur. She will enlighten us on the topic of single-dose COVID-2 vaccine in outcome of single-dose COVID-2 vaccine in kids compared to booster dose in adults. So I hand over to Dr. Prama Bagani Bafna to start her presentation. Dr. Bafna, you can start your presentation. You share your screen.
Unmute first.
A very good evening to one and all. And after this power-packed clinical topic, I shall be taking you to a journey through a little epidemiological and dry topic. So by saying this, I think I have already reduced your expectations from me. Without much ado,
Please make full screen, doctor. Can you please make full screen?
Is it not, ma'am?
No.
One sec.
If possible, otherwise go ahead.
No, ma'am, I'm not able to.
Go ahead, go ahead.
Okay, is this clear? Is this slides, are the slides clear?
You need to be in a slideshow mode. So in the bottom towards the right side, there is option editable mode, then slide sorter, and last one is the whole PowerPoint presentation mode. Or you can upstairs over there and go to the slideshow. On the upper top, there is a fifth button is slideshow. Do it from there.
Sir, I'm not getting any
Okay.
options here. It's all, the whole screen is occupied.
Then you stop sharing and just again go to sharing and select the full screen wala. Then you will get it. You will see one is the open PPT and another with the full screen PPT. Select that open wala. Then you will just come to the full screen. Share again.
Now?
Again, yeah. Acha, you just go to slideshow.
Yes, sir.
Yes, sir. I'm on the slideshow. Now what do I do?
On the slideshow, just click the slideshow.
You have to click it. Yes, click it.
Just
click
click,
it.
double click karo usko.
Right side in the bottom.
This and okay, 1 second.
Now you just go to that. No, not that. That is a zoom. That one. Double click that one.
I click. Sir, it's working on single click. Actually, I'm not able to double click it.
Okay.
I'll just try it one last time.
Yeah. Then you go the upper row of slideshow. Go to the upper row slideshow.
Yes,
After
sir.
room, insert, design, animation, and slideshow. Click that
Yes,
slideshow.
sir.
Click that slideshow.
Okay.
Slideshow. Have you clicked the slideshow? Then it is a from beginning, and then click the from beginning. No, slideshow. Fourth one.
Yes. Not displaying here.
No, not that.
No, it is that.
Go
Design.
slideshow. Go on slideshow.
Okay, slideshow. Yes, sir.
Now from beginning. Go from beginning.
From beginning.
Double click करो उसको. करो click.
कर दिया, ऐसे आया.
Double click.
Double click करो from beginning को. फिर से एक बार करो.
Okay.
See, Prama, may I suggest that you go to the screens when you've got the options. There is one
Yes,
left
sir.
side option. Go to screen. You
Okay.
click on that and then you come there. Probably that will help.
So when I'm going to slideshow and I'm clicking on from beginning,
Double click.
it's on a single click, it is opening.
Okay, then Pallavi madam, are we having the PPT of
No,
madam?
no, what you do is you come out of that again, and when
Yes.
you go for screen sharing, you
Yes,
have got
sir.
on your screen, you will be seeing multiple options, out of which one is PowerPoint. Don't go to that. Go to the screen option on the left side. And on that, once you click on that, then you will be seeing this PowerPoint also. There you go to the PowerPoint, and then you will be able to show us the slideshow method. That would be better.
Okay, I'll just
Pallavi madam,
okay.
तेरा आएगा
Now
slide?
I will go. No,
no.
sir, she doesn't
screen.
have my new slides.
Go to screen sharing.
Yes, I have gone to screen sharing.
Ma'am,
First,
before screen
first
sharing,
open your
the
presentation. First, you have to open the presentation, then share it.
First open the presentation, then click on the
Yeah.
share screen, ma'am. Don't click
Okay.
first.
First,
I
you
have
will open the screen, then open this PPT, then minimize it, then go for this sharing.
okay, sir. Now I have opened the presentation.
No,
Yes.
but now you share
click
it.
on the share screen button, ma'am.
In one.
Have you clicked?
Yes.
Now you will be getting multiple windows. Click on your presentation. There will be multiple windows.
Yes, ma'am. But I'm not seeing my presentation there.
You have not seen your presentation. Have you opened the presentation?
Yes, ma'am. It's open on my screen.
Okay.
Okay.
Just
So share-
open it full screen. Which full screen?
I have made this full screen and now I'm
Make it minimize. Dr.
yes, it is minimized.
There's
No.
an email ID of Dr. Neha. Please share your PPT on my email ID. I will share.
Should I select PowerPoint as virtual background?
No, ma'am, no.
No. You have to share it.
You have to just click on the share screen and
Yeah.
select your PowerPoint window. That's it, ma'am. Nothing else.
Okay, just give me a moment. I'll do it.
Close everything and start again.
Yes.
Yeah, it is opening, ma'am. It is opening.
Now,
yeah.
now what do I do so that the screen is big enough for everybody?
Just click on the slideshow button. Click on the
This?
slideshow button.
नहीं ऊपर.
Yeah. It will do, ma'am.
अच्छा, मैम यहाँ पर इसको maximize
नहीं।
करना है क्या?
नहीं.
100.
Yes, click on this. No, not that.
Okay.
Yes, on that.
You are clicking on the perfect button.
This is the one I have.
Yeah.
Shall I start?
Yeah, ma'am. Please
No.
start.
Okay.
But still, it is not there. No, anyway, you continue, please. Yeah.
Okay. So my topic is breakthrough SARS-CoV-2 infections in double and triple vaccinated adults and single dose vaccine effectiveness among children in autumn 2021 in the real-time assessment of community transmission 1 study. So these are two different topics. I'm not going to be comparing the vaccine effectiveness between adults and children. This will be published in the month of June in Lancet volume 48 online. And the impact factor of Lancet is 79.321 in 2022, which is the third highest amongst journals. So moving ahead with the introduction, the REACT-1 study.
Your slides are not moving.
Better you email your presentation to someone and someone will play for you.
Okay, I'll do that.
You can send your presentation to Dr. Neha Singh. So she will do the needful.
Yes, sir. I'll do that. Ma'am, could you just message me your email ID?
Yes, I have.
I have already sent the email ID.
Okay.
May I request Dr. Prama, you will have to cut short your presentation little bit because we have lost around 5 to 7 minutes.
Yes, ma'am.
Yeah,
I'll try to wind it up early.
Yeah, please.
Madam, Dr. Chitra, let her take the full
Yes,
time. I
sir.
will rather cut short. I will not take it altogether because she should present everything. My slides are not important. Let her present.
Okay,
those.
sir.
Yeah.
Okay, sir.
Sure. She had prepared very well. Let us see. So, Dr. Vapna, carry on.
Ma'am, I have sent it to you. Neha, ma'am?
Yes, ma'am. I have not received yet.
It will be.
It's without a subject, like I have just hastily sent it.
No, sorry, I didn't get that.
My email ID is docprama. Have you received it, ma'am?
Resend it. Resend it.
No, I haven't.
Ma'am, I'm sharing my email ID also.
Resend it. One easy email ID. Write HR Gangolia if you want.
Ma'am, I'm sharing my ID also. Please send it to me.
Hello.
Yes, sir.
Ma'am, have you received my? I have written my ID on chat. It's contact@exposureinfotech.com. Just send it.
Okay,
to me.
I'll just resend it.
Yeah, forward it to me, ma'am.
Mohanty sir, take presenters take own time. Cut short करू नका कोई जरूरत नहीं है. Hello.
Okay,
Yes,
okay.
sir, पूरा होने दो. अच्छे से होने दो.
Okay, sir. Okay, sir. Point taken, sir.
They have taken a lot of efforts. Just properly present करने दो. No issue.
Sure, sir.
And sent again.
मैडम चैट बॉक्स में एक और ईमेल आईडी उस पर भी रीसेंड कर दो आप.
हाँ मैम, सर मैं भेजती हूँ और एक ईमेल
एक
आईडी
और
पे.
ईमेल आईडी मैंने चैट बॉक्स में डाला है, उस पर भी डाल दो.
ओके सर.
Just forward to this email ID.
Yes, sir. I have forwarded again. I have forwarded to this one also now. Has anybody received it yet?
Not yet.
Not yet, ma'am. Not yet. I'm trying. I'm refreshing again.
HR गंगोलिया पे भेजा क्या आपने?
हाँ सर, उस पे भी भेज दिया. मुझे sent दिखा.
Just अच्छा okay.
Sir, is it possible that share in your group and you can forward on WhatsApp? Is it possible?
Wait a minute, I have received.
Yes,
Okay.
now click there.
Thank you very much, Dr. Neha. And I'm extremely sorry, everybody, for technical glitch. Okay, next slide. This study has been tracking the spread of SARS-CoV-2 virus in England from September onwards, September 2021. And the national vaccination program against COVID-19 began in England along with the entire UK in December 2020 with Oxford AstraZeneca vaccine, which is vector-borne, non-replicating vector-borne vaccine. And the Indian subpart that we have been using is called Covishield. Vaccination was extended eventually to include children aged 16 and 17 years, and subsequently children aged 12 to 15 years. And the children vaccination as well as the booster dose of the vaccine that were used was Pfizer or the Moderna vaccine, which is an mRNA-based vaccine. And what they concluded was individuals who had received 2 doses of vaccine had a lower but appreciable risk of becoming infected with the Delta variant even at home. So this is a retrospective observational study. And ma'am, next slide. So the probable objective of this study was the authorities and public health services noted a breakthrough infection in adults who had completed their course with 2 vaccines. And so they wanted to find out the role of booster dose in adults. At the same time, they had introduced vaccine in children in the age group of 12 to 17 years recently. So they wanted to check the effectiveness of vaccine in children. And probably they also wanted to assess the limitations in their study to help better surveillance in future studies. Now, what I mean by probable objective is that in spite of this being an important article published in a very important journal, somehow the pitfall here is that they have not mentioned objectives of the study anywhere. So this is what I have assumed as an objective from my reading of the topic. Before going ahead, I'll just introduce you to the types of vaccines available in general and especially for COVID-19. They're either whole cell virus vaccine or component viral vaccines. And whole cell vaccines can be either inactivated or live attenuated. And the component vaccines can be of various components like protein subunit, virus-like particles, DNA-based, RNA-based, non-replicating viral vector, and replicating viral vector. Moving ahead. In short, about the methodology, the study population consisted of 2,59,955 participants, that is around 86.9% who had consented to link their REACT-1 profile to vaccination data from the NHS. The testing of RT-PCR was done, and it was tested. It was considered positive if both N and E gene targets were found, or if the N gene was found with a cycle threshold of less than 37. Now, these positive RT-PCR tests were subjected further to viral genome sequencing using the ARTIC protocol version 4. And for statistical analysis, they used the R software. So here, talking about the results, as we can see that weighted prevalence of SARS-CoV-2 swab positivity by age groups discussed here in these bar graphs in rounds 14 and 15. Round 14 is a previous round and round 15 is the last round of this study. So here we can see that the prevalence in 5 to 12 years age group has increased maximum by nearly 5.27%. And in the 13 to 17 years age group, it has increased by 4.9%. Also, we can see here that the prevalence has increased in the age group from 25 to 75 years between the 2 rounds. So this was because the Delta variant had become very prevalent during round 15 of the study. And in spite of the adults being vaccinated completely with their 2 doses, there was breakthrough infection. Next slide, please. So here, can everybody see when I'm using the pointer? When I'm showing the screen with the pointer, is it possible for you all to
No,
appreciate?
I think Dr. Neha can do that.
Okay, never mind, sir. I'll just emphasize on some, last slide, ma'am. I'll just emphasize on some important points in these slides. So here we can see that in round 13, the first line, unvaccinated, the prevalence of positive test was 1.49%. And in round 15, it has reduced very marginally to 1.16%. But at the same time, when you see that those who were vaccinated with 2 doses of all vaccines, the second line in round 13, there the prevalence was only 0.41%, which had almost tripled in round 15 to 1.10%. So what we can see here is that even when the adults had received both the doses, in the earlier part of the study, in the beginning of this study, the 2 doses were acting very effectively, but then there was waning of the vaccine effectiveness, and there was breakthrough infection also in the setting of Delta, and also because probably the restrictions were lifted in England at that period. Next slide. Here we can see that in 18 years and over, and also the healthcare workers who had received booster doses. So they have compared the vaccination effectiveness of booster dose with those who had received only 2 doses. So as we can see that the odds ratio for the booster doses 0.36 in 18 years and over. For those who are a little statistically challenged like me, odds ratio is just an association between an exposure and an outcome. So when we say that odds ratio over here is 0.36, ma'am, can you just click again on the slide, because there's a small animation that I have here. So this is how we calculate the odds ratio, AD upon BC. So odds ratio of 0.36 means that those who have received the vaccine booster dose will have only 36% chance of testing positive. So booster dose has given almost 64% effectiveness against the virus, the swab positivity. Next slide, please. Here, this slide is sharing about the vaccine effectiveness in children.
What's the temperature?
So,
95.7.
So what I want to talk about here in short is that I'm sorry, I think somebody else is.
Please don't talk in between. Somebody is speaking, please.
There is some disturbance. Kindly mute yourself.
Okay, so vaccine efficacy is measured in a very controlled clinical trial and is based on how many people who have received the vaccine have developed the disease compared to those who have received the placebo. But what we have calculated here is vaccine effectiveness. So vaccine effectiveness is a measure of how well the vaccine works in the real world. So as we can see in round 13 to 15, the unvaccinated children were almost 11,360 who tested negative and 380 who tested positive. But by round 15, the unvaccinated population had drastically gone down. But overall, the vaccine effectiveness in all the rounds ranged between 58 to 67.7%. Ma'am, can you click on this slide? So by this, what I mean is that I'm just taking a small part of this particular graph and trying to tell you that in round 15, considering all children, the unvaccinated population was about 3,003, of which 207 had tested positive. So that is around 7.4%. Those who had received a single dose were roughly 1,827 participants, and 53 had tested positive. So that is 2.9%. And those who had received either 1 or 2 doses, by 2 doses, I mean actually the 16 to 17 age group, those even they were almost 2.8%. So either single or 2 doses had hardly any difference in their effectiveness. But at the same time, the effectiveness was almost more than 50% compared to unvaccinated children. Next slide, please. So the conclusion of this study is that booster dose was found to protect adults almost 3 times compared to those who had received their 2 complete doses by any of the vaccines. The increase in prevalence in older people suggests that transmission can be sustained among both vaccinated as well as unvaccinated population. And here I'll just make a small comment that they had seen that the transmission was seen more in households where there were children. So children were probably acting as very good carriers. And at the same time, in households where there was overcrowding. So like any other disease, contagious disease, this was spreading fast amongst this kind of people. And post-vaccination program in adults, there was weakening of the association between prevalence of positivity and COVID-19 related hospitalizations and deaths. This is the conclusion related to adults. In the next slide, we'll see the conclusion related to the children. Ma'am, next slide, please. The prevalence had risen markedly in the children, ranging up to 5% from 5 to 15 years of age group, especially because of the Delta variant and also because of uplifting of all restrictions in England. And at the time when this data was collected, vaccine was not approved for less than 12 years. So we do not have that data with us. And school-age children on exposure were seen to have more chances of testing positive compared to adults. And at the same time, higher rates of infections in school were detrimental to learning and education all over the world. Children who had received a single dose, like we have already discussed, had almost 50% reduced risk of testing positive. And following the rollout of vaccine to children aged 12 to 17 years, 64% vaccine effectiveness was seen against any infection, and particularly against COVID symptomatic cases, it was 67.7%. So they have declared a few limitations of this study, especially because this was a retrospective observational study. So there was some risk of bias in the form of confounding by indication, which means that those who had any comorbid condition, they were not able to avail the vaccination on time and were not even able to complete their vaccination. And those who were healthy, like healthy vaccine bias means those who were healthy, they were more keen on getting their vaccination completed. Also, the estimate is less strong in this study compared to the studies where symptomatic individuals approach the national testing programs, because this study is not based on test seeking behavior. These are just data linked to their vaccination program and NHS. And at the same time, those who consent and do not consent may vary. And then those who have completed their vaccination might be more keen on linking their data compared to those who have not taken the vaccines. Next slide, please. Just going a little off the topic, I wanted to discuss a little about differences in the immune response of adults and children. So discussing the immune response in adults, the purple part. So adults can have comorbidities in the form of obesity, hypertension, diabetes, and other conditions. So this can lead to either increased response of the ACE2 receptors or transmembrane serine protease, and at the same time, even exaggerated response of the endothelial damage and hypercoagulable state. Now, these factors act at every step of disease acquiring and also disease outcome. So viral entry, infection, disease. Then the disease itself leads to endothelitis and hypercoagulation. At the same time, excessive inflammation and ineffective viral clearance, especially in patients with COPD, which leads to severe COVID-19. Now, considering the protective immune response in children, the green part, the lower green part. So in children, due to recent vaccinations, recent viral infections, recent COVID exposures, they have an heterologous immunity or cross protection, which is again a debatable topic, but we have seen that vaccines can give some cross protection to infections. Also, the immunomodulatory factors like vitamin D and melatonin, which enhances both innate and adaptive immunity, are present better in children. The only drawback of immune response in children is immunosenescence or chronic CMV. What we mean by immunosenescence is age-associated decrease of adaptive immunity. So this is noticed commonly in children. Next slide. So I'm just summarizing my take on this topic, that school age children are very susceptible to, I'm just going to be discussing about children mainly. And school aged children are very susceptible to testing positive on exposure, and early vaccination drive in school aged children will help us to reduce the burden on medical infrastructure, which increases a lot during winter seasons. And some children with COVID-19 can become seriously ill. We have all had experiences with MIS-C and long COVID. And lockdown, as we all know, has played a havoc with the psychosocial health of children. So we really cannot afford another lockdown for the sake of children. And where adults who require 2 or even 3 doses for improving vaccine effectiveness, children have actually shown a remarkable effectiveness to just a single dose. What we as practicing pediatricians can do is we can support the government of India's decision to vaccinate children between 2 to 18 years of age group. And this can be achieved honestly only when we educate and encourage parents and teachers. This can be achieved through various platforms like public forums, like these talks, messages on radios, if we involve a socially acceptable figure. So I think this will help, like how Amitabh Bachchan was involved with vaccination drive from the beginning. And we should partner with Government of India in the implementation and surveillance. Surveillance, I would really want to emphasize on, because if we make this as a prospective study, then I think we can have better idea about the statistics. And this epidemic, hopefully in its exit phase now, has prepared us for any such future medical adversities. Just a small data that I had found online. Booster dose coverage in adults is currently at 2% in India, and in the Omicron era. So we all know that all these vaccines are for the ancestral strain of COVID-19, but the strains have changed over time. We had Delta, now we had Omicron. So the effectiveness against Pfizer vaccine, they had declined, particularly for those between 5 to 11 years. In spite of that, it was very protective against severe disease, and so it is still highly recommended. And in India, the partially vaccinated population is ranging up to 93%. Those who have received their full 2 doses are 81.61%, and booster dose, like I had already discussed, 2%. And in the age group of 12 to 14 year, the exact figure is, I think, around 4,80,61,600. The future prospects of this study is that prospective studies can be planned on similar methodology. Vaccine-specific effectiveness can be studied in Indian children because currently we are using 3 different types of vaccines. Statistical analysis and data can push the envelope for research funding for the future. And we can strategize better with public-private partnerships for the ongoing as well as future novel organisms. Thank you very much.
क्वेश्चन आंसर नहीं होता इसमें.
Thank you, Dr. Parma, for your beautiful presentation. Now I wish Dr. Abhishek has expert comments on this.
Yeah. So good evening, everybody. At the outset, I thank MahaIAP and IIP Raigad for giving me this wonderful opportunity. And it was an excellent presentation by Dr. Prama Bapna. And probably I must appreciate her because she has gone through every line and has put it in a very short capsule. It's you have done a commendable job. Now, number one, the paper itself is going to be published in Lancet and with a very good impact, 3rd highest. So this paper speaks volume about the complexity and the uncertainty of the pandemic. Of course, we are now think that we are in a fake end of the pandemic and probably everything is going to be okay. But as far as the vaccine efficacy and effectiveness is concerned, as rightly mentioned by her, that we need to have a large prospective population-based study. But this is a retrospective study, and I will put now one of the comment. Number one, that there is though there is an original Wuhan strain was there, the variants are coming. And out of that, there are variants of interest as well as variants of the concern. And the present article has suggested that it was in the peak of the Delta. Means the variant of concern has made a very havoc. And this Delta has been followed by the Omicron. Now, in spite of a large amount of vaccination in the European country and the Israel, in fact, the Israel is the first country where the first booster was given to all the population, all the people, and 4th dose, that is the second booster, was given in some select person. But in spite of this, there is an unprecedented rise in the weekly cases, nearly 11,000 cases per million every week. So this is after even 4 doses. So that means that the vaccine effectiveness has certain limitation. And which are the limitations? So we know that animal studies are also proven that when that person or the animal has been vaccinated, the viral load at the site of lower respiratory tract is very, very low. But there is hardly any difference as far as the nasal shading of the virus is concerned to the both in the vaccinated as well as in the unvaccinated persons. So the message is that this vaccine has been a game changer as far as the prevention of the severity is concerned, as far as the death is concerned. But as far as the community perspective is concerned, I think the prevention or the protection offered by this vaccine is very, very limited in terms of the mild infection, symptomatic infection, as well as in the transmission of the disease. So that is very, very important. So in spite of doing a great job by the vaccine, in spite of large amount of vaccines have been covered by the India, this vaccine has probably failed or has a limitation as far as the prevention of the transmission is concerned, number one. Second thing, that most of the vaccine that has been created is of the original ancestral strain, and this vaccine will have a mismatch between the circulating virus and the vaccine strain which is used in the vaccine. And as a result of this, the amount of the neutralizing antibody may be high, but they may not have a functional capacity to neutralize whatever the antigen is present in there. Number 3, COVID virus itself has a unique propensity to have an immune evasion. And because of this immune evasion, whatever the immunity has been obtained, either by the vaccine and or by the infection, is going to wane over a time. And that is why the booster dose has been implicated all over that. And in spite of the booster dose, even there has been a waning of the immunity, both against asymptomatic disease, mild infection, as well as against the hospital. So if you look at the Moderna vaccine or the Pfizer vaccine, in spite of the third dose, there is a reduction. There is immunity, the waning of immunity even in the severe disease. So I think the booster, so there is no end. How much booster is available? No one is knowing. That is why more studies are required. And last, my comment is that for the not only B cell or the immunoglobulins are required for the protection, T cell response is also required. And there has also been studied that the COVID vaccine is such that the interacting with the various epitopes have been found that it often causes the T cell dysregulation. And therefore, the uniformity of the T cell response is not there. So this is all the limitation. So by this means there is no way out. But yes, we need to take the vaccine. We need to follow the COVID appropriate behavior to protect ourselves from the severe disease. And as I rightly mentioned that even a single dose in children is very, very important because children are the most important vectors. So if in the family someone is older one, someone is diabetic or a comorbid adult is there, if the child is moving from the school, go to the school, comes back and is unvaccinated, this new infection is going to occur in a elderly sick person and it becomes a very detrimental to his or her health. So vaccinating a children is also very, very important in spite of that high herd immunity. And last one, do we have any way forward? Yes, we can have it. Number 1, we can have a priming boosting arrangement. Means you give a primary vaccine with a good vaccine, like you can use a messenger as a priming and use an intranasal or mucosal vaccines. Once you use this intranasal mucosal vaccine, it will help prevent the transmission chain. Second, we can have a variant of concern specific, means variant specific vaccine. But again, here the studies have been saying that Omicron specific variant vaccine was studied, but again, it has not have a promising result as on date. So we've got only few studies there, but again, it's not there. And third one, we can have a multivalent or the multivalent vaccine. These are the 3 important things that we can go with. But most important that this vaccine is very, very important for the prevention of the death, hospitalization, ICU admission, and for that a booster is very, very important for the elderly children, and a single dose is also important for the children. Thank you so much.
Thank you so much, Abhay Shah sir, for your expert comments. Now I like to request Mohanty sir for giving his comments.
Hello.
Mohanty sir.
You need to unmute.
Sir, please unmute. Mohanty sir, please unmute.
Yeah. So, so is it what visible? No.
Sir,
Yes,
it is
sir.
visible.
Visible?
Yes, sir.
Yes, sir.
Make it a slide, so sir.
Is it okay?
Yes, sir. Yes, sir.
Yeah, I will take only 4 or 5 slides I've kept because a lot of time has gone. So where I will start where Dr. Abhay has left. This is exactly what I was going to emphasize. The T cell mechanism.
Yeah.
So we very much know that these humoral antibodies are directed against the glycoproteins, that is surface proteins, these spike proteins. And when there is a change in mutation and the virus, the variety of concern comes in, so they may escape these antibodies, or over a period of time the antibody may decrease. Like, whatever the antibody level after 3 weeks had decreased to 1/5 after 6 months. So that is the concern. So humoral antibodies is not enough. We have to see that vaccination is a proven powerful strategy, we know, but emergence of virus of concern on long-term decline of vaccine effectiveness and incidence of breakthrough infections are major concerns. So vaccine efficacy is observed declining in 6 months, and declined effectiveness is attributed to reduce neutralizing antibody titers emerging of the very of the concern by mutation. Cell-mediated immunity, which is the other aspect of the immunity, and the conservation of the T cell epitopes, what Dr. Abhay just now mentioned, in these various varieties of concern, might be playing a bigger role in prevention from severe infection further. What they have observed, there are non-COVID coronavirus infections also. They, in a paper in 1916, they say that the CMI remained up to 11 years. In some studies have reported 17 years. So that is persisting more than the antibody response, this humoral antibody. So this is very important, that antibody titer need not be the only guide. The vaccine efficacy is focused only on aspect of this. See, the antibody level we measure, and when the antibody level declines after some periods, we say there is no effectiveness of the vaccine. We should not forget about the T cell, which is contributing the effectiveness. There is no definite, another thing, there is no definite correlation between CMI, specific response, that is how the CMI is measured, and the humoral immunity, which is measured by quantifying the IgG. So this is very important. There is a strong inverse correlation between COVID-specific interferon gamma producing CD8 and the disease severity. So disease severity, it products even after that humoral antibody has subsided, decreased. Disease severity is also taken care of this CMI over a long period of time. If the patient gets the disease as the infection, it is a mild infection, what we see, and this is because the CMI is playing the role. It is a powerful weapon, effective against human coronavirus family, including SARS, CD8 cells, and CD. What happens? They produce a lot of cytokines like interferon gamma and TNF alpha, and these things, they go and kill the virus-laden cells of the host. So the majority of the virus is also eliminated by the killing of the cells. So this is a good thing. Now that's why so many newer vaccines in the pipeline, where these T cell epitopes have been used, and the CMI provided is complete, effective, resilient, lasting protection of SARS. So compared to antibody, this is very, very useful. CD8 cells and CD4 cells. And SARS-CoV-2 specific T cell response reduced by 10 to 22% in variants like alpha, beta 1, the newer variants you can see. And 93 to 97% CD4, CD8 T cell epitopes as conserved in variety of concern. So these cannot evade T cell than the antibody. The multiple T cell epitopes distributed across the structural and non-structural viral proteins, that the virus is taken care of this T cell mechanism than the humoral antibody only. So to conclude, these SARS-CoV-2 variants could escape the neutral antibody. So these induced by the vaccine were able to bind to the surface, but they were less capable of neutralizing them. CMI immune response reduced by most currently used vaccines is very resilient and remain effective. T cells were largely as responsive to the variants, to the type of virus. They were able to recognize and respond effectively to variants. This is very important, conferring resilient protection against severe disease. Severe disease protects long term. So T cell mechanism persists after the humoral antibody comes down. The greater focus should be placed on development of vaccines capable of producing antibodies, but would predominantly elicit cell-mediated immune response against COVID. So we are unlikely to achieve herd immunity. We are waiting for the herd immunity to develop, but it never came. The rational goal may be by recognizing COVID as a controllable disease, then we can eradicate it. Similar to flu or common cold, we have vaccines every year for the flu vaccines. Breakthrough infections are mild with low viral load. It's a reduced transmission risk, but at the same time cannot be ignored. Need of vaccine that induce durable, broad, protective T-cell mediated immunity. It provides stronger defense than the antibody. So until then, we must continue current vaccination program to prevent severe load. And a lot of vaccines are in the pipeline, which we will see in no time. Thank you.
Stop sharing, sir.
Thank you, Mohanty sir, for your expert comments. Are there any questions from audience?
And one message
Sir,
is
I
there.
want to ask one basic question.
Yeah, please.
So should we advise COVID vaccine to now the younger age group which is coming? What about the herd immunity? And should we do the immunity level, antibody level before asking them to go?
And there is no need to go for the antibody checkup before the vaccination, number one. Second, we need to follow the law of the land. We should not give up the paper or any vaccine which is not recommended or not approved by DCGI. Because this is a vaccine mainly for the emergency use. It's not a routine one. If it's a routine vaccine, we can take a chance, but I don't think that we would put our leg in that basket.
And that's mix and match combinations have come to recently the Vellore study. They have seen the if the booster is given from another vaccine, so the antibody titer is very, very high.
Yeah.
Sir, I would just like to interrupt here. In the Vellore study, they studied that when 2 doses of Covaxin was given and the booster was given with Covishield,
yeah,
the antibody titers are very good. But
reverse
if
is not
we
true.
go the other way around, it was not.
It is not
true.
Yeah, that's there. That's the observation. Yeah, true.
And what Dr. Mohanty sir said about T cell function, I think though T cell is more important as far as the B cell is concerned I say for the prevention, disease attenuation and prevention of death. I think the COVID is one virus where again the T cell function has been distorted. And in the individuals where the T cell function has been distorted, they have gone for the ICU or they have high mortality. So though the T cell is important, it is not a sacrosanct as far as COVID is concerned.
True. The component vaccine in the pipeline, a lot of studies are being done.
Yeah.
Study by J&J vaccine in UK and the Japanese study recently using this about these T cell functions are very glaring. Newer studies are coming up.
But given a choice, I think we need to give better is a sub-unit vaccine in terms of immunity and safety.
Yeah, that's true.
I'm talking about pediatric patient, because RNA vaccine is not available in India. So till we have got the 3 vaccine, out of that, I think sub-unit vaccine scores over.
Bharat Biotech claims that their vaccine causes a T cell through it acts through T cells also for the long-term immunity. They claim, I don't know the proof.
I think there are,
Vikas?
Yeah, I think there are no more questions. Special comment for Dr. Prama Bafna that especially after this technical glitch, speaker becomes bewildered, but she maintained her composure. I really congratulate for maintaining her cool mind and gave a very beautiful presentation. And also, now I request our dynamic secretary, Dr. Dhananjay, to give the vote of thanks.
Thank you, sir. It was yet another wonderful session of Journal Journey. We are really fortunate to have blessings from Dr. Raju Shah, sir. Thank you. On behalf of Raigad IIP as well as Maha IIP, I sincerely thank Dr. Raju Shah, sir, for accepting our invitation as the guest of honor today. I sincerely thank two of our experts today, Dr. Abhay Shah sir and Dr. Om Prakash Jamadar sir, for their valuable inputs related to both the articles. I sincerely thank two of our wonderful speakers today, Dr. Vijay Mali sir and Dr. Prema Bafna madam, for presenting two important articles in a very crisp manner. Heartfelt thanks to our own Dr. Mohanty sir for his persistent guidance to every session of Journal Journey. Sincere thanks to Dr. Hemant Gangulia sir, our beloved MahaIP president. Sincere thanks to Dr. Jay Bhandarkar sir, the state convener MahaIP. Dr. Pramod Wankhede sir, President Raigad IIP. Dr. Vikas More sir, Vice President Raigad IIP. Dr. Ajay Kohli sir, Dr. Chitra madam, and Dr. Neha madam. I sincerely thank Pallavi madam for making the Zoom platform available for this wonderful session. And finally, sincere thanks to all the delegates who have attended this session. Thank you. Thank you very much.
Thank you so much.
Thank you, Dhananjay.
Thank you.
Nice.
Thank you. Thank you. Very